Is there a max dose to vasopressors? Hello there, farmers and friends. Mark with Pharmwyze. I'm a board-certified emergency medicine pharmacist that makes clinical pharmacotherapy content for learners of all medicine backgrounds. I post patient cases and infographics on my social medias, where I'll often get questions in the comments. I'll compile them into a weekly to bi-weekly video series called the Drugqueryinbox. For our first Drugqueryinbox questions, we'll also talk about thoughts on appropriate ST elevation, myocardial infarction aspirin dosing, the utility of early high-dose statins in heart attacks, and whether I'm in the ketamine hole while I make my content. Let's dive into the first question that comes from my Instagram broadcast channel poll, which is there a max dose to vasopressors? Technically, there is no max dose of vasopressors, but there are limits placed by your hospital. There comes a point of diminishing return, and you should be working towards a solution. Increasing rates of vasopressors for someone appropriately resuscitated in refractory shock are going to need what their body needs. Let me emphasize that high-dose vasopressors are independently associated with mortality. They're a band-aid, not a solution. Plurad and colleagues in 2010 published a retrospective single-center trial and included all ICU admissions that survived past 24 hours. They were assessing whether fluid status had an impact on mortality in patients requiring vasoactive support. Mortality occurred in roughly 44% of patients needing vasopressors compared to the 4% of the no vasopressor group. These findings were independent of fluid status. Vasopressors are a useful tool in order to buy time, but don't forget the general risks of extravasation, dysarrhythmias, and human error amongst many other complications. Whenever you're increasing the rate on vasopressors, always triage to ensure medication delivery. Is there a backer of fluids to keep the line patent? Did the line blow? Has a patient actually been appropriately resuscitated? Additionally, consider if this is a case for vasopressin and/or hydrocortisone, which has shown early resolution of septic shock. There's a lot going on with complex patients. Just remember, what is the underlying etiology causing your shock? You should be working on a plan that includes no vasopressors. Our next question comes from Darren Figgis on X, and his question is, what are my thoughts on aspirin dosing and if the patient is on an anticoagulant and baby daily aspirin? Guidelines have a range of 162 to 325 milligrams of aspirin because really there isn't an established lowest effective dose. In a lab, 100 milligrams of aspirin would theoretically completely block synthesis in thromboxane A2, the pathway for platelet aggregation. Berger and colleagues in 2007 retrospectively evaluated mortality and bleeding risk in 162 versus 325 milligrams of aspirin from two large STEMI fibrinolytic trials, Gusto 1 and 3, that contained over 56,000 patients. From their results, there was an association of reduced bleeding and possible similar efficacy with the lower dose. However, that's the issue with retrospective aggregate numbers. You remove the robustness of each individual trial inclusion and exclusion criteria, leading to results without causation and only association. Mittal and colleagues completed the current OASIS 7 trial in 2010. This was a randomized 2x2 factorial design trial that included over 25,000 patients with an acute coronary syndrome and arranged for percutaneous coronary intervention. Patients were to receive clopidogrel 600 or 300 milligrams on day 1, followed by 150 and 75 milligrams daily, respectively. Additionally, patients would receive higher dose aspirin determined as 300 to 325 milligrams daily, or lower dose consisting of 75 to 100 milligrams daily. Their primary outcome was a composite of cardiovascular death, myocardial infarction, or stroke at 30 days. There was no difference in efficacy nor safety outcomes between the larger clopidogrel and aspirin doses compared to the lower regimens. Generally, I lean towards full dose 325 milligrams of aspirin, unless rare, patient-specific considerations would warrant a lower dose. Even if a patient is on a daily aspirin and anticoagulant, I would still give 325 milligrams. The patient could die from a heart attack right now, and that's because of a blockage of the coronary arteries. We just need to get the patient to the final solution, which is percutaneous coronary intervention or systemic thrombolytics. Even with a possible increased risk of downstream bleeding, that can be managed. We need the patient to be alive in order to get there. Our next question comes from Zuby797 on Instagram. Their question is, why do we give statins in the acute setting? I always thought they took some time to take effect. That's a great question there. The proposed benefits are potential downstream effects on modulating endothelial function, inflammation, and thrombosis. There may be a reduction in stent rethrombosis, contrast-induced nephropathy, and peri-procedural MI. It's important to note that cardiology studies like to use composite outcomes. Lee and colleagues did a randomized controlled trial in 2010 for more definitive evidence, since meta-analysis associated early high-dose statins with a reduction in major cardiac events at the time. From their results, there was not a reduction in the primary outcome, but they did see improved coronary flow as a secondary analysis. Possible benefit and questionable clinical significance, but low risk. Recent meta-analysis continue to support the potential benefits of early statins. They do associate the use of statins, in this case, with increased adverse drug reactions specific to statins, such as transaminitis and myalgias. I wouldn't force a horse-sized statin tablet down a patient's throat or delay care by having to grab a cup of water. If the patient's stable enough and the conditions are appropriate, I'd consider high-dose statins after prioritized antithrombotics have been given. For our last question, it comes from TikTok from user Susan in Venice Beach. She asks, is he in the K-hole while recording this? No, I am not in the K-hole while recording any of my content, but I'll use this opportunity to explain how ketamine works. Ketamine antagonizes the N-methyl D-aspartic or NMDA receptor, leading to a reduction in glutamate, an excitatory neurotransmitter. This results in dissociating your brain from external stimuli like sound and pain. That's what makes ketamine such a strong anesthetic and sedative. Another property of ketamine is the potent amnestic properties. I would be impressed with anyone who can produce logical, educational content and remember exactly what they said afterwards. Ketamine has gained huge media traction recently, given use for refractory depression and the influx of ketamine clinics. That's FDA-approved ketamine. I'm not sure what your street ketamine does. It is often preferred since it maintains respiratory drive and considered to be more cardiovascular stimulating compared to the other depressive GABAergic sedatives. Ketamine is a sympathomimetic since it inhibits reuptake of catecholamines. Caution in patients who are catecholamine depleted, since ketamine's minor mechanism include negative inotropic effects, which could be detrimental in someone without circulating catecholamines. All of ketamine's mechanisms, properties, and pharmacokinetics can be discussed entirely in a separate video, which I'll do sometime in the future since there's so much interest in its multiple indications. Let me know in the comments below what questions you have on medications, emergency medicine, and critical care. I'd appreciate if you hit the subscribe and notification bell, and make sure to stay tuned for my Code Blue debrief, YouTube, and podcast episodes. Follow my social medias for pharmacotherapy content, or stop by my website at pharmwyze.com, and I hope you learned something new.